first patient we used it on was one of our ALS patients who clearly, the upper airway was not being utilized anymore, and she could not tolerate being turned for every suppository medication. So we were able to get the catheter in once, and the last 2 weeks of her life was much better, much better. And she was young. She was 48 years old. So that made a huge change. She could even speak to her little girl because she wasn't miserable. Recently, just the other night and it's always in the night, that at 5:30, 6 o'clock, the guy's been out of control all day long. No matter what they do, now he's gotten combative. Not only is he screaming in pain, now he's agitated, he's trying to climb out of bed. Of course, his wife is a tiny little thing, and of course, he's a big guy. And now they call the son-in-law in, and they're trying to hold him down. And I've got my nurse has come upon the scene, and she's like, okay, they said they can't take this anymore. He has end-stage pancreatic cancer. He's about 48 years old. Again, a young man. We've had a slate of very young cancer patients lately. And the family can't stand to watch this anymore, and you have to put him in the hospital. You have to put him in the hospital. So, P.S., he doesn't live, within 10 miles of the hospital. He's one of our people who live way out in the country, so to say, like 25 miles away. And now we're now past that 6 o'clock hour. So if we're going to get an ambulance or transport to bring him in, he's not going to hit the hospital doors till 9:30, 10 o'clock. So we still have from 6:30 to 10 o'clock to try and do something. And they've tried everything. And finally, the nurse that was out there, she goes, let me try one more time and see if they will accept the Macy catheter, because I think it's going to make the difference. And I said, okay, try again. We've already discussed this with them 3 times during the week. Different approach, different nurse, now in a much more, anxiety-ridden situation. Okay, try it. Put the catheter in. She calls me 40 minutes later. She goes, we're fine. Forget it. We're not moving anywhere. We're staying here. And I said, really? And she goes, yeah, they even have a paid caregiver coming in. I'll give them the directions for the meds. I'm like, good job. So the family was incredibly happy. All of a sudden now the wife felt she could handle it because he calmed down. And it was not a function of giving him enough medicine. It was giving him the right route. The patient doesn't really feel it. B, the family has no problem putting medicine on their leg because you tape the little catheter, acceptance point to the leg. And that's fine, because asking somebody to give mommy a suppository when, we're seeing families where the patient's 98, the son is 75. This is just totally against their mindset, is that I'm not supposed to be touching my mother down there, let alone putting something in there, so that you have the nurse, administer the tool, so to say, show them how to use the tool, and it works out much better. So it's very good technology that's very low, it's not high tech. It's just smart. Sometimes we even tell them, we'll spin it as it's a little bit more natural than sticking her with needles and putting it into her vein. We're going to use her natural way to absorb the medicine. And they've gone, oh, well, okay, we could try that. Again, sometimes it's the way you deliver the idea. Number one, pills are cheaper than liquids. And if you can use an MSIR pill as opposed to morphine sulfate elixir, Roxanol is more expensive milligram per milligram than a pill is. So right there, you're already going to save some money just by virtue of that. The same with all the other medications that we give sublingually, it's a lot less expensive. So I would never compromise somebody's care based solely on money, but if I can do the same thing cheaper, why not? The catheter is reusable, so if it comes out, you don't have to go get a whole nother clean one and you just wipe it off and put it back in. So for most patients are not using these for more than 30 days, which is the lifespan. So that usually works out fine. Nursing-wise, it's not nearly as labor-intensive, or you don't need to monitor it the way you would a PCA or a pump. Pump requires every dose change to make the nurse go out there with the pharmacist on the phone and reset the thing. So sometimes you change a pump once a day. That's 5 nursing visits in a week that you're going to be taking somebody out of the, one visit to go to that visit. So you can easily tell somebody, a family member over the phone, okay, instead of giving him 1 tablet of the morphine sulfate, give him 2 tablets when you give a dose. So that's going to save that manpower also. Those things alone should be enough to make you, when we were in the hospital, it was even better. We weren't using intravenous medication, which is even more expensive than sublingual. So we clearly, there's an economic perspective to this that, most doctors don't like to talk the money part because, it makes us look like we're too invested. But it is reality when you're talking about running a hospice program. You only get a certain number of dollars a day, and you have to learn how to make it stretch. Once I get one nurse to use it, they are just sold. The rapidity with which the absorption happens and how well it can bring the symptoms down really makes everybody realize it does make a major change in what we do. Sublingual medications are usually what we use, particularly in the home. And when people get to a certain point, they're really not being absorbed sublingually. They become oral because people swallow, or they just end up in the bed sheets. And the catheter makes a huge change.